1, 2, 1, 2.
Okay, we're testing the microphone. 1, 2, 3. Sounds good.
Good morning to all of you. Welcome to our webcast, It's All in Your Head. And today we'll be talking about fibromyalgia and chronic fatigue. My name is Rita. I'll be the moderator. And I do have to say I'm quite intrigued by today's topic. I'm sure we all have time periods when we feel really tired and we have muscle aches and we just feel unrefreshed even after sleeping for a good amount of time, like me this morning. So how do we know whether we are just having a tough week or whether the chronic fatigue syndrome is kicking in? Well, we have Dr. Swingle here today to answer these questions and explain how neurotherapy can be helpful in treating these conditions. As some of you may know, Dr. Swingle was titular full professor of psychology at the University of Ottawa prior to moving to Vancouver. Fellow of the Canadian Psychological Association, Dr. Swingle was lecturer in psychiatry at Harvard Medical School, attending psychologist at McLean's Hospital in Boston, where he also was coordinator of the Clinical Psychophysiology Service. Dr. Swingle is a registered psychologist in British Columbia, certified in biofeedback and neurotherapy. His book, Biofeedback for the Brain, was published by Rutgers University Press, and the book is available at www.soundhealthproducts.com. Again, that's www.soundhealthproducts.com. Before I invite Dr. Swingle, I'd like to urge you to take this opportunity to get your questions answered. Just type your questions or comments in the chat box, which is located on the control panel. We will have 2 breaks today, and we will use these to answer your questions. Okay, let's get the party going. Good morning, Dr. Swingle.
Good morning. So, hopefully this time around everything will work properly. You know, trauma is one of the causes of fibromyalgia, and with the problems we had with the last broadcast, everybody has a bit of pain today. Okay, fibromyalgia and chronic fatigue. These conditions are really very fascinating in my judgment. These clients who come in with these conditions often have been through all kinds of medical and healthcare treatments. They're very often disparaged. We see a lot of literature associated with, is fibromyalgia a real disorder? Is chronic fatigue a real disorder? 20 years ago, that was very prominent. People just assumed that these were whiny people who, you know, if they just simply get up off the couch and go out and do something, that they wouldn't have time to think about all of their pains and fatigue and so forth and so on. And I was really startled to see the other day when I was looking through one of the news feeds, the health news feeds, that the title of the article is Fibromyalgia, Is This a Real Disorder? So what we're going to be doing today is looking at the neurological conditions that are associated with fibromyalgia and chronic fatigue. So let's just get started here. The first thing that I always do when I have a client come in with almost any condition is I screen for traumatic brain injury. Because if you look at the characteristic symptoms associated with traumatic brain injury, they mimic a great many of the conditions that we deal with. And they certainly mimic a lot of the conditions associated with attention problems, concentration problems, and it mimics the various forms of ADD. It mimics the high frontal alpha form, which is a problem with planning, organizing, and sequencing. It certainly affects the concentration and inattentive forms. It mimics chronic fatigue. It mimics depression. It mimics irritability and mood swings. So a lot of the things that we see on a day-to-day basis in our busy practices, and a lot of that can be associated with traumatic brain injury. So I always screen and see whether we're dealing with anything of that nature. Okay. Symptoms and characteristics of fibromyalgia. What we're going to see here is the culprit is sleep. Now, these individuals, what they're complaining about is pain. So they have soft tissue pain, multiple and diverse painful points. The painful areas tend to shift around. They have swelling. They have headaches and often irritable bowel and TMJ. They have problems with concentration, short-term memory, multitasking. That's the fibrofog that they will complain about. They find that their condition is exacerbated when they get under stress. But if you look here, sleep disturbance, 85%, frequent wakings, 60%, non-restorative sleep, 60%. Now, there are multiple causes of fibromyalgia. What we typically find is that the individual has had some sort of emotional trauma. We also find that they very often have had a serious viral infection, flu, for example. They very often have had an injury of some sort. Many of the folks will talk about having had an automobile accident in which they've had a whiplash kind of injury. And we get variations and combinations associated with all of that. Now, these are the EEG patterns that we're going to be talking about as we're moving through the discussion of fibromyalgia and chronic fatigue. And what we're going to be doing is focusing on where in the brain we find these anomalies. Now, the thing that is very interesting, you'll notice here we talk about that we have a similar pattern for viral infections, allergies, toxic poisoning, post-trauma, especially whiplash. That's what I was just referring to. So we get a lot of the patterns, brainwave patterns that we see with people who have had viral infections or experiencing allergies, toxic poisoning, and so forth. And for those of you who have never seen a brainwave, I'm going to show you an actual brainwave in just a moment. But delta are very slow waves, 2-3 cycles a second, associated with sleep, can also be associated with pain and injury. Theta waves, and these are the culprits that we're going to be talking about. These are brain waves between 3 and 7 cycles a second. And we want to see a lot of theta in some areas of the brain, and we don't want to see a lot of theta in other parts of the brain. And this is the culprit that we're going to be looking at, the theta. We'll also be looking at alpha, which is a rhythmic, smooth kind of wave, and beta is very fast frequency, 16 to 25 cycles a second. It's associated with attentiveness. Now, this is an actual brain wave measurement of a person. And a few features on this that we want to talk about. This is the brain wave spectrum, as it's called, and this is showing you that how strong a brain wave is. So this is a brain wave right in here of 2 cycles a second, and this is how strong it is. The higher that bar goes, the stronger that waveform. Now, one of the first things you will find in a normal brainwave pattern is that it looks like this. That is, the lower the frequency, the higher the amplitude. So it should have that nice kind of excursion down so that the fast frequencies are very weak, the slow frequencies are strong. Now, when you get changes in that pattern, there are symptoms associated with that. Now, the guy we're going to be really interested in is this one up here, the blue one. That's theta. And we want to see a lot of theta in the back of the brain. We don't want to see a lot of theta up over the top of the head, and we don't want to see a lot of theta frontally. And when we see those kinds of conditions, those are the markers that go up in our clinical assessment of these conditions. And again, what we do is we have a look at how the brain's functioning, and when we see anomalies, that is conditions that do not match normative functioning, then we ask the client whether they have symptoms that are consistent with the changes we see in the brain activity. And those are things we're going to be talking about in detail today. So again, the pattern should look like this, nice smooth transition down, lower amplitudes at higher frequencies. And theta should be nice and clean, and it should be where it's supposed to be and not where it's not supposed to be. Okay. Now, what I was showing before in that slide of the EEG patterns, what we're going to find in a lot of these conditions is we are going to find excessive fast frequency back here. So you're going to see that the back of the brain does not have enough slow frequency and often has too much fast frequency. And what that's associated with is problems with quieting the brain. So you have poor stress tolerance, predisposition to anxiety, often self-medicating behavior, sleep quality problems. That's the biggie. And fatigue and worn out feelings. A lot of chatter in the brain. The other thing that we're going to find is we have complications in this area of the brain. Excessive slow frequency. Now, here's a problem in which we don't have enough back here, okay, and we have too much up here. So theta is in the wrong spot. We also often find that we have too much slow frequency in this region as well. And those are the kinds of conditions we're going to be looking at. We'll look at some actual client data. Okay. So, good. Now, the diagnostic criteria for fibromyalgia. I don't pay much attention to diagnosis because it really isn't very helpful. What we want to know is what's going on in the brain. And we look for areas of inefficiency in the way the brain's processing information. That tells us what we want to know. It tells us what the condition is, and it tells us, more importantly, where to go to fix it. But in terms of the mandatory industry we have of naming things, these are the conditions that we use for naming. A history of widespread pain for at least 3 months. Pain is on both sides of the body, above and below the waist. It moves around, and it's present in the axial skeleton. Pain in at least 11 of 18 tender points on digital pressure. And it's not just tender, it's painful. And we're talking about 4K of pressure here. The question I always have is, what if you've had it for 2 months? What if you only have 10 of the 18? So this is silliness as far as I'm concerned. These are the 18 spots they're talking about in terms of painful on palpitation. Okay.
Okay, thank you, Dr. Swingle. This is our first break, so you have about 5 minutes to get a quick coffee and your questions answered. I also would like to mention that we have monthly newsletter for which you can subscribe at our website, www.swingleandassociates.com. And the next issue coming out on July the 1st will include article written by Dr. Swingle about fibromyalgia. So if you are interested, make sure you are on our list. Okay, I see first question coming in. Dr. Swingle, I have fibromyalgia and I'm always tired. I sleep a lot. I use sleep pills, but I'm always sleepy. Can your treatment work for me?
Yes, I'm going to be talking a lot about sleep. Sleep is the most important feature of the treatment of fibromyalgia and chronic fatigue. One of the hallmark features of fibromyalgia and chronic fatigue is oversleeping. Individuals sleep and they're tired and they sleep more and they get more tired. The interesting thing about oversleeping is that the longer you sleep, the more tired you become. Now, what that means, and the reason for that, is the sleep quality is poor. And this is the central feature in the treatment of these conditions, to get good quality sleep. If you do that, you fix virtually everything. Now, the culprit here is deep wave sleep. You only need 30 to 50 minutes of deep wave sleep, but it takes a long time to get there. And if you have interrupted sleep because of pain, for example, then you're never getting into deep wave sleep. And you feel tired, so you go to bed, and you are sleeping not in deep wave. So the longer you stay there, the more fatigued you become. So it's a very, very vicious cycle that gets set up. The neurotherapy is extremely effective for these conditions in terms of correcting the brainwave activity associated with the fibromyalgia, the pain conditions, the poor stress tolerance, and the conditions that are associated with the sleep disturbance. Medicated sleep is not restful sleep. And again, the longer you sleep, the more tired you become. And you probably have had that experience. No matter how much sleep you get, you just can't get out of that chronic fatigue.
Another question. I know a male who claims to have chronic fatigue disease, and I think he's just lazy. How can you tell if the person is really sick?
Well, if it's an 18-year-old male, have the mother lock the refrigerator. To be serious about it is very often difficult to determine what kind of condition you're dealing with. Depression is the big issue here. Very often individuals who go into severe depression mimic chronic fatigue because the depression is depriving them of motivation and interest, and they just can't get themselves going. And the diagnosis of chronic fatigue is very often applied in these circumstances. From our perspective, the best way of assessing this is to do a brain assessment. If we see the markers for chronic fatigue or depression or fibromyalgia or whatever, then we treat those conditions and send the person on their way. If we find that we don't have any brainwave activity consistent with the claim of chronic fatigue, then you're probably dealing with a different issue altogether. So the answer to your question is have a brain map done. Then you will know whether you have the neurological conditions that support the claim of chronic fatigue.
Okay, I see some of you are asking how do you submit the question in. So again, if you look at the control panel, which is on the right-hand side on the screen, you'll see the tab with chat on it. If you click on it, it will open a chat box, and that's where you can type the question. Another question we have here. So should they give us sleep medication before they start neurofeedback for this condition?
No. You want to avoid the sleep medication. Now, having said that, I don't have a knee-jerk reaction against medication. You may benefit from having some sleep medication for a week or so to try to get yourself into a slightly better state. But the bottom line here is we want to change the neurology associated with what's causing the sleep disturbance. Medicated sleep is not restful sleep. However, having said that, there may be conditions in which you must be medicated in order to get from place A to place B so that we can get started here.
Okay, another question. I had a car accident almost 30 years ago and been suffering from muscle pain. How can you tell if this is a physical issue or brain issue?
Again, if you do a brain assessment, you can determine whether there are any conditions associated with the fibromyalgia or chronic fatigue or pain. Now, if you've had an accident, very often what happens is what's called short muscle syndrome. And we refer a lot to people who do what's called intermuscle stimulation, which is a procedure designed to release and relieve the short muscle problem. We do that a lot in conjunction with the neurotherapy that we do. And the intermuscle stimulation deals with the muscle and the muscle issue associated with the pain while we're doing the neurotherapy to correct the what's traditionally a sleep problem.
Okay, and we'll just answer one more question for now, but we do have another break coming up, so we'll get to the rest during the second break. Dr. Swingle, how long does the treatment for fibromyalgia take?
That can vary tremendously in terms of number of sessions and time. Basically, I tell clients that you will notice a difference within the first 3 or 4 sessions. It's usually that quick. In terms of the total number, I think you should be planning in the neighborhood of 20 to 30. Now, it depends on why you have fibromyalgia. And also, we typically see people over a 2-year period, although during the last year, we probably only see you 2 or 3 times to make sure it's stable. That is, the changes are stable.
Okay, thank you. So as I said, you can just keep sending the questions. We'll get to the rest of them during the second break.
Okay. There is a genetic component associated with fibromyalgia. Now, if you look at the children of fibromyalgic parents, about 28% of them will have conditions associated with the fibromyalgia, blood relatives, and it tends to be predominantly female. Now, you're going to find that in all of these conditions that it's primarily females who you see in fibromyalgia, and there are good reasons for that, by the way, in terms of some of the anatomical and muscle activity associated with childbirth and so forth, which makes the female more vulnerable to these conditions relative to the male. There are comorbid conditions associated with fibromyalgia. This is one, for example, it indicates that restless leg syndrome 11 times more likely if the client has fibromyalgia. And again, you tend to see this more in females than in males. But again, the culprit here is sleep. It's not a trivial condition. You know, this notion of are these just people who are whining? If you look at some of, again, the comorbid conditions, if you look at mortality ratios, death from suicide, death from cirrhosis and biliary tract disease, cerebral vascular disease, much higher with fibromyalgia. And again, it tends to be female. Males do not tend to have significant increases in these other mortality issues as opposed to females. And this is relatively new in terms of identifying children who have fibromyalgia. You know, our stereotype of a fibromyalgia patient is a 40-plus-year-old female. We get a fair amount of this with young kids. Now, this used to be misdiagnosed of growing pains. A lot of older folks in the audience who are in my age range know that kids that complained of this sort of thing were always told that or the parents were told that it were growing pains. But again, if you look at the culprit here, sleep disturbance, 96%. So this is putting up all kinds of flags. The way that you go after this is make sleep restorative. And if you do that, you're going to have a profound effect on fibromyalgia, chronic fatigue across all of these conditions. Now, this is an actual brain assessment of a fibromyalgia client. And I'll show you what this looks like on a brain schematic, but I want to just show you how we identify these things. First of all, in the back of the brain, and that's O1, what we're seeing here is the relationship of theta, 3 to 7 cycles a second, to beta, 16 to 25, is 0.61. It should be 1.8 or higher. So this person is 1/3 what it should be. I know immediately this person has poor stress tolerance, predisposition to anxiety, serious sleep problems, and a lot of chatter. The brain is just not efficient at self-healing and recuperation. The second thing, huge disparity in beta in the front part of the brain. On the right, it's twice what it is on the left, and that's the marker for predisposition to severe depression situation, which is exactly what she reports. The other thing, which is the hallmark feature of fibromyalgia, is elevated slow frequency up predominantly in the right relative to the left side of the brain. Okay? Now, this person is medicated, so we find that the ratio of slow to fast alpha is quite a bit higher than what it should be. And some of these medications slow down alpha, which means it slows down brain efficiency. The alpha measure correlates with IQ. So some of these medications slow everything down, which is why they work, of course. So this is what we look at here, and this person didn't have to say one word to me. I knew that she had severe anxiety issues associated with severe sleep problems, that she had marked depression, and that she was having a lot of problems with what she would call fibrofog, in the sense that she has problems with concentration and focus and so forth. So this is, just 22 different measures that we have, and it tells us absolutely everything that we need to know. Now, what if this lady had only 9 of the 18 pressure points that were sensitive on 4 kilograms of palpitation. Okay, so the diagnostic category means nothing, really. You know, what we need here is what is the brain telling us and where to go to fix it. This is another client. Again, we have the deficiency in the back of the brain. Again, and again, we're picking up the major marker for sleep disturbance. And the difference with this person is what we know now is a marker for trauma, exposure to severe emotional stress. And emotional trauma is one of the conditions we often find with fibromyalgia. And what it is a very poor alpha response, and we can spot it immediately. Okay? And again, here's that elevated slow frequency up on the right side of the brain. Okay? So, fibromyalgia. What we tend to find is elevated slow frequency up over on the right. When there's a depression component, we often find marked elevation of beta, again over here. The real culprit, however, is in the back of the brain, in this area right in here, where we have a marked deficiency in the theta-beta ratio. And what that means is poor stress tolerance, predisposition to anxiety, can't find peace in your own head, can't shut the brain off. But the biggie is poor quality sleep. Now, individuals will often say to me, no, I don't have any problem sleep. I sleep 14 hours a day, but I'm always tired. And the problem there is not how much time you spend in bed, but how much time you spend in good quality deep wave sleep. Now, we have methods for analyzing how much deep wave sleep you get. There's a device we give people to take home, and they wear it at night. It's pretty crude, but it gives us a decent idea of whether they're getting any deep wave sleep. Sometimes we don't even have to bother with that. We just see in terms of what the brain is telling us, we know that sleep quality is an issue. Okay, and now the other thing that we often find was what I pointed out in the one of those slides, in which we have too much slow activity, slow alpha, right in this region in the brain, and that's your fibrofog issue, and it's often exacerbated by medication. Trauma, the way we identify trauma is, and we look at brainwave activity right up in here, and we look at brainwave activity back here. And what we're looking at is the difference between eyes open and eyes closed. And we found that there's a difference in the way one of the brainwaves functions between eyes open and eyes closed with individuals who have been through an emotional trauma. Where I discovered that is working with combat veterans over at McLean Hospital who had post-traumatic stress disorder. They have a profound deficiency in one of these brain waves. And I found that in the lesser conditions that individuals would admit to having been exposed to a severe emotional stressor, a traumatic stressor, and they have all of the, of course, legacy and sequelae of that. And it's highly, we find it very, very frequently in fibromyalgia patients.
Okay, thank you, Dr. Swingle. This is our second break. And just to remind you, if you are interested in reading the article written by Dr. Swingle about fibromyalgia, which will be included in our next newsletter coming out on July the 1st, make sure your name is on our mailing list. If you are not on our list, you can email me at rita@swingleandassociates.com. You can see my email address on the screen. or you can subscribe to our newsletter on our website, which again, www.swingleandassociates.com. Okay, I see lots of questions coming in. We are going to have 1 minute break right now, so I can just form all the questions here. And we'll have Dr. Swingle answer them in just a minute. Okay. The first question is the muscle stimulation therapy available in your office?
Okay. No longer. We used to have a physician who did the intermuscular stimulation do it in our office, but it was just more efficient to refer to one of several people in the Vancouver area who do it.
Okay. I let my friend who has fibromyalgia borrow my CES machine, and she noticed an instant release of muscle tension. She doesn't live in Vancouver, so can't so she can't, I guess, do the treatments, but would she benefit from getting a CES machine?
Yes, a lot of our fibromyalgia and chronic fatigue clients use CES devices that we prescribe for home use. They're extremely efficient for sleep and depression and anxiety. In the United States, they're FDA compliant or FDA certified, I guess is the term, for treatment of depression, anxiety, and sleep. So yes, if she's not able to do any neurotherapy, she can certainly get a CES unit and use that for relief of pain and so forth. There are other applications of CES unit. You can use it on areas of pain, directly on the pain. We have electrodes that we use specifically for that purpose.
How do you distinguish fibromyalgia and chronic fatigue, or are they the same thing?
They differ slightly. Often you'll find that chronic fatigue is the preliminary condition, and then it evolves into fibromyalgia. The hallmark difference between the two is pain. If you get the pain that moves around and pain at some of these sites on palpitation, that's usually the distinction between fibromyalgia as opposed to chronic fatigue. But we often find that one evolves into the other, and fibromyalgia folks usually are severely chronically fatigued as well.
Can you do too much with CES?
There's no evidence of that. We get that question a lot, and what we find is that when people first start to use it, they use it quite a lot, and then as they improve, they reduce the frequency of use. It also is very useful for cognitive efficiency. We have a lot of CEOs who use it every day for increasing brain efficiency. And if you study with the use of a CES unit, there are certain conditions in which you can increase retention of information by quite a substantial amount. My daughter and I did a paper on that, 10 years ago, I guess, in which she was looking at retention of information in second language acquisition, and she was getting improvements in the region of 40% with the use of a cranial stimulator. It's interesting, but there's no evidence of any negative effects of prolonged use. When we're working with our addicts, severe addicts who are just coming off a drug and they're in serious withdrawal, sometimes they'll wear the unit for 24 hours a day for a few days just to get over that severe period of craving.
Okay, we have time for 2 more questions. Is there any correlation between fibromyalgia and Meniere's disease? I have a friend that has both.
No, I don't think there is. We get a lot of folks who come in who have Meniere's and fibromyalgia, but I don't know of any evidence that suggests that they are related. Now, if the Meniere's is giving rise to sleep disturbance, and Meniere's, of course, for those folks who don't know what that is, it's a problem of the ear in which there's severe or can be severe nausea and vertigo, and it can be sleep disturbing, and individuals often try to treat this with some sort of anti-nausea medication, Gravol being one of them. If it affects sleep, then that could be the link, between Meniere's and fibromyalgia. But other than that, I don't think there's any direct relationship that I'm aware of.
Thank you. And last question. My mother was told that there was little that could be done for fibromyalgia other than sleeping pills and anti-inflammatory drugs to help with the pain. I actually spoke with one of your former patients who said she was 100% better and off her drugs. Why isn't your therapy used with all fibromyalgia patients?
I had a professor when I was getting my master's degree who had a very profound influence on me. And among other things, he said, Paul, the one thing that you have to remember is it's not science, it's politics. Now, extending that concept, when people have a hammer, everything looks like a nail. When an industry makes a huge amount of money by making sure that you need that product for a long period of time, then there's strong disincentives for introducing anything new. That's a long-winded way of saying we're not up on the radar, and there's a lot of resistance to the changes that we're trying to make, and we run into it all the time. We run into it with our healthcare associations. You know, we've been trying to set up a free, by the way, we are paying for it ourselves, facility in a mental health association, running into a lot of resistance. We have offered to set up in schools free of charge to get some of the very basic treatments for kids that have problems with attention. Run into huge amounts of resistance. And there's a psychiatrist who's working with us who's trying to get this at least to get the psychiatric community to at least look at this, and he's running into huge amounts of resistance. You know, as he maintains, psychiatry does not have any metric. You know, how do you measure any of these things? And our clinical cues that we use for assessing these conditions is a neurometric, you know, but we're running into all kinds of problems there in terms of getting it up on the radar. The bottom line is it works, and if you talk to people who have had the treatment, they will verify that. And we've got data out. There's a lot of data on this.
Thank you, Dr. Swingle, and we will move on.
That didn't sound like an answer to a question. It sounded like I was on my soapbox, didn't it? Okay. Okay. Chronic fatigue. Fatigue of unknown cause. Well, we know what it looks like in the brain, and there are a lot of things that give rise to it, and it's very similar to fibromyalgia. Trauma is a huge issue, and viral infection. I find the combination of those two plus a deficiency in the back of the brain, the type that we were just talking about, we almost always find with cases of chronic fatigue. Now, I think what the pattern is an individual has a deficiency in the back of the brain, so they have poor stress tolerance. They have problems with getting good, refreshing sleep. Okay, they're then hit with a series of viral infection. They do not have good recuperative capabilities because of the deficiency in the back of the brain, and they may have had an exposure to an emotional stressor. You put those together, and those are the people that are most at risk, and that's typically what we find. Now, the syndrome, fatigue, and I'm not talking about a person who's just tired. These people have difficulty getting themselves up and ambulating. Serious cognitive problems. They really feel foggy and can't find their words and can't plan and organize. They usually have some kind of complex that you normally identify with viral infections: sore throat, tender lymph nodes, muscle pain, joint pain. Sometimes they have unusual pattern headaches, and sleep, big problem. Oversleeping is very, very, very common. And exertion fatigue. Now, everybody gets tired when they exert themselves, but these are individuals who might walk around the block and need 2 days to recover from it. That's what we mean by exertion fatigue. We have to rule out that we're not dealing with the viral phase of the problem. So we want to rule out chlamydia, candida, Lyme's, Epstein-Barr, mono, infectious diseases, yeast infections. The other is depression. Often I see folks who I think are more appropriately labeled as depressed, and they are behaving and self-defining their condition as chronic fatigue. Again, the labels don't mean a lot because we look at what the brain's telling us and fix it. But it's an interesting pattern to see how the depression is manifesting. And chronic fatigue can often be associated with that, which is why some physicians will try antidepressant medication right out of the box. If somebody comes in and say they're chronically fatigued, they will try an antidepressant to see whether they get any positive benefit by treating the depression, if in fact that's the underlying cause. Here's a chronic fatigue client. This is that waveform that I said that's associated with trauma, and the person has it in both places, up on top of the head and in the back of the head. Severe deficiency in the back of the brain. Remember, we were talking about the theta-beta ratio. That should be up around 1.8. This person's about half of that. Front part of the brain. Again, we have elevated slow frequency, primarily up over the right. We also have a marker for depression, predisposition to depressed mood states. Okay, and we have the elevated slow fast alpha ratio, which is the fibrofog. Now, this person could very easily have come in and said, I have fibromyalgia, as opposed to chronic fatigue. And the reason I'm showing you this one specific slide is that the condition between chronic fatigue and fibromyalgia at a neurological level often looks very, very similar. The good news is this is telling me what to do to fix it. Now, the other reason I'm pointing this out is whenever we get these markers for trauma, emotional trauma, we have to keep in mind that what we may be dealing with here is the sequela of the trauma, and that is that the individual has to deal with the traumatic content, and we have very efficient ways of doing that. Neurologically, when we correct this, there'll be an emotional reaction to it, and that may be all that's necessary. The person acknowledges it, experiences it, dreams more about it, may chat with us for a session or two about it, and that's the end of it. Very, very efficient, most efficient psychotherapy on the planet. Okay, again, fibromyalgia and chronic fatigue, patterns the same. There's your trauma markers. There's your deficiency in the back of the brain. And there's your depression. Okay, now what we have talked about is elevated slow frequency in the front, elevated beta on the right, hallmark feature, deficiency back here. This sets everything up. That is your pre-existing condition, your predisposition to all kinds of conditions. The brain is not efficient at self-restoration. It's not efficient at calming. It's not efficient at sleep. Pediatric chronic fatigue, typically teenage females, severe school absenteeism. They report a lot of inflammatory conditions. It's unlikely in patients younger than 10 years of age. I'm not sure it's the same condition, really. And we see a fair number of females who come in with, they have this diagnosis, but I think it's more psychological. But we have a look at the brain activity associated with it. But very often we do some work with these individuals in terms of core emotional belief about themselves. Often they've been exposed to a trauma. What do we do about it? Well, what we do is we do neurotherapy, and there are several forms of neurotherapy. This is one in which we have an electrode sitting on top of the head. We have reference electrodes on the ear, and when the brain's doing what we want it to do, this thing moves. So the child is playing a video game with their brain. Now, in this particular case, we let adults do this as well, by the way. But basically, when the brain is doing what we want it to do, for example, increasing slow frequency in the back of the brain or decreasing the slow frequency up over the right side of the brain, the brain's doing what we want it to do, that spaceship moves. When the brain's not doing what we want, it stops. Okay? So it's a straightforward feedback situation. Now, we also have the client watch the raw signal. And there are various ways we can give them feedback. Over here, there are bars, and what we tell a person, for example, is to make that bar go as high as possible or as low as possible, depending on what we want to do. And a lot of adults just like to see the raw data, and we give them feedback with the raw data. But the most powerful technique that we have is called brain driving. Now, I've been working on developing brain driving for many, many, many years. And what brain driving is we measure a particular aspect of brain functioning. Based on that measurement, we stimulate with light, sound, microamperage stimulation, EMF fields, and so forth to nudge and push the brain into more normal functional ranges. Now, this is a setup in which this individual has sounds, the harmonic sounds that we use. We have harmonics that increase or decrease slow wave activity and so forth. And she has control of the intensity of the sound. We use lights that we can vary the frequency of those lights. So for example, if we wanted to encourage a brain wave of say 12 cycles a second, these lights would be flashing at 12 cycles a second, and they would come on at certain times to enhance that 12 cycle strength. She has control of how strong that is. So we always give the client some degree of control, so there's no startle effect here. She also has electrodes on what's called pericardium 6, which is an acupuncture point. And if you stimulate that point at various times, it increases slow frequency in the back of the brain, which is the sleep issue. So this is an enormously effective and very aggressive. I don't mean dangerous. I mean we're doing a lot at the same time. This is why our treatment treatment rate is about half what the industry standard is, because of this kind of procedure that we use. And then we use regular neurofeedback to stabilize those changes. There are a lot of practitioners around the world who are making use of my brain driving technology, and it's available through a lot of different agencies, so those clinicians in the audience who might be interested in this. Okay, here's a fibromyalgia client, unusual, a male, 70 years of age. He was physically attacked and beaten around the head, shoulders, and neck. Okay, so here we have both a physical trauma and a psychological trauma. Here's a 70-year-old man who's beaten, okay? And he had both of those. Now, the pain started in the head, neck, shoulders, and remember, it's skeletal, and then moved to other parts of the body. A hallmark feature of fibromyalgia. Major complaints: sleep, 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 sleep. First one right out of the box. And then, of course, all the other things. Concentration, which is the fibro fog. Problems with planning, organizing, sequencing, following through on things. Depression, fatigue, and, of course, the related irritability associated with that. Now, we ask people to keep some sort of log in terms of what the treatments are, and here is an individual. He didn't have a huge number of treatments, as you can see, and extended over quite a period of time. He was working at home using our relaxation tapes, and he was using a cranial electrical stimulator, so he was doing a lot of treatment at home. Here's his sleep log in terms of how much time he felt he slept. Okay, and quite a substantial increase in clock time, at least. And pain, he had a very complicated method for evaluating pain, but in any event, the larger the number, the more severe the pain. You can see that drop nicely. And this is one of our better markers. How many days do you have where you'd say you have no significant pain? He started off, he had no days without pain. At the end of treatment, 2/3 of the days of the month, he was pain-free. So this is the kind of thing that you see, but you can see that's 1 year. So he was in treatment for a year, but he only had about 8 treatments, plus his home treatment. Okay, Again, the book that Rita was telling you about, and for clinicians, we have the Clinician's Guide, and we do a lot of training here, so clinicians in the audience who are interested in any of our training procedures, give us a call and be happy to chat with you about it. Thank you very much.
Thank you, everyone. This is the end of our webcast. We hope you enjoyed it, and we'll be looking forward to seeing you on Saturday. That is a typo. Excuse me here. I think I didn't catch it. I believe today is July the 9th, isn't it, Dr. Swingle?
Let's see. July 9th is a Saturday, right? Okay.
July 9th, yes. Okay, so yes, our next webcast will be on July the 9th, which is going to be the Saturday, and we'll be talking about epilepsy and seizure disorder. Again, thank you, Dr. Swingle. Thank you, everyone, to be on July the 9th, and have a great weekend, everyone.